Well, welcome. It's my pleasure to introduce Michael, but I think I will start off by actually welcoming his family. It's good to see the family here. His mother and father, John and Loila from Gore. I presume I'm looking at them. And his wife, Fiona, and his three daughters, Alice, Charlotte, and Emily. So having been through this myself, I know how important it is for the family, and it's important for the university as well as the family. So welcome, and I hope you are entertained by this. I think we all will be. So my job is to actually outline why Michael has received this accolade, and its purpose is not just to receive an accolade. The purpose is to actually put him in a position where he may continue on within the university. Such a title helps with research grant applications and how you are seen across the rest of the country and across the world. So we don't see this as the end. We actually see this as actually achieving a certain level of excellence that actually supports the university in continuing to move forward, and certainly that's true for the Dunedin School of Medicine. So the story for Michael, I think, is quite interesting. I try and spend some time before I do these introductions trying to understand how people move, what pathway they move through to actually get to this position. And so I did sit down with Michael, who I actually know in another form because he's also my cardiologist. So I've got to, so I've actually got to say the right things. He might give me the wrong prescription. But it is an interesting story. He comes from Gore, was born in Gore, and brought up in Southland. And this is important, I think, as we move forward. Because the Dunedin School has really important connections with Southland, and we now see, in fact, the Dunedin School of Medicine almost as being the Southern School of Medicine, and we see the Southland area as really part of us, and we hope that we're moving to the position where the competition is less, and we actually see that we are part of Southland as well. So it's really important to see that we're becoming a unit rather than two competing bodies. So Michael came through Southland, went through school, high school in Southland area, did medicine at the Otago Medical School, and in fact graduated in 1985, just at the time that I was coming to Dunedin as my first year as a consultant. So it shows you my age. He went through medicine. He got one of the top prizes at the end of his undergraduate training. He then went on and did a diploma of obstetrics. It tells me that he had some difficulty in quite deciding what specialty he would go into. Finally decided medicine was the way he was going to go, and then into cardiology. He was a health surgeon, registrar, a cardiology registrar, and then a clinical tutor at Dunedin Hospital. So he's not moved very far at this stage. He's staying close to home, so to speak. And then he goes to Boston, to Massachusetts General Hospital, where he has a research fellowship to study echocardiography, and then is awarded a repatriation fellowship from the Southland Medical Foundation to actually then come back really doing full-time research as a senior research fellow for approximately 4 years. At the end of that time, he applies for and gets a job as a consultant in Dunedin Hospital, and that's a full-time job. And he's effectively stayed in a full-time hospital role until about 2 years ago, when he's had a 2/10 university appointment as well. And so that's important, because when you think about somebody who's actually delivering a clinical service for the bulk of his actually working time, how do you then attain a professor's role within the university? So I was curious about how this happened. He was appointed because he's now got 122 peer-reviewed publications, which is hard to achieve. 2 chapters in a book. And when you look at the list of grant or studies that he's been involved with, it goes for at least a page and a half. The story is more of a person that, how do you do this when you're actually in a full-time job doing something else? And so this is what I was trying to pin down, and from my observation and my discussion with him, it seems to be that there are some people who observe, are curious about what's around them, and want some questions answered. He tells me that he's quite a meticulous person and that he likes everything in the right place. And when things are not making sense and not in the right place, he likes to put them in the right place. So he likes numbers. But I was reminded of the story about about the scientist who discovered penicillin, who did it by looking at the growth of a contaminant of a petri place where there was bugs growing, and the fact that the bugs didn't grow because of a fungus growing on that particular petri dish. Observed that, and that led in the due course to actually the discovery of penicillin. So people who actually observe what's around them, get curious, get annoyed when things are not right and try and understand why they're not right, and then proceed to actually follow through on that. Now, following through when you're a full-time clinician is just about impossible unless you connect sideways with other people who are actually doing lots of other research as well. So it's the combination, I believe, of the curiosity, the wanting things in the right place, but also serendipitously sometimes connecting with people who will help answer the questions. And so when you look at his career and look at the publications, they're actually always working with somebody else and bringing to a collaborative team the clinical view of things, the connection sideways, the saying you can't say that is stupid if you don't know the clinical scenario. So he's brought the clinical breadth of a practicing physician into the research question that has allowed the research questions to actually be much more tailored to real life and answering real questions rather than some tiny thing that's not relevant. So he's made sure that the research he's involved with is very relevant to society. And I think that leads us really nicely to the topic of his talk, the prevention and cure, the fight against cardiovascular disease, still the largest cause of death. If you're going to die, the chances are it's going to be cardiovascular disease or cancer. And so he's taken one of the biggest areas of causes of death in New Zealand, and he's going to now talk to us about his approach and his thoughts about the prevention and treatment of cardiovascular disease. Thank you, Michael.
Professor Squire, Professor Taylor, thanks very much for that kind introduction. Ladies and gentlemen, this evening I'm pleased to take the opportunity to share with you some of the exciting advances in cardiology during the last half century, and in particular the huge progress that has been made in treating coronary artery disease. Before considering this topic, we need to have an understanding of what coronary artery disease means. The coronary arteries run over the surface of the heart and are small 2 to 3 millimetre sized vessels. Coronary artery disease is the accumulation of cholesterol and blood fats inside the wall of the artery, which is called a coronary plaque. Fats in the wall of the artery gradually accumulate and narrow the artery such that blood flow is diminished, and when persons are exercising, they develop symptoms of chest tightness, otherwise known as angina. A heart attack occurs when a clot forms on this coronary plaque, blood flow is obstructed, and the person suffers severe chest discomfort. The rate of coronary artery disease in the community has been strongly influenced by improvements in socio-economic status, cigarette smoking, increased food consumption, excessive alcohol intake, and physical activity. It sounds like all the list of vices. Coronary heart disease was actually uncommon as a cause of death in the early part of the 20th century. As a consequence of industrialisation, increasing urbanisation and growing prosperity, coronary artery disease prevalence increased rapidly over the first half of the 20th century, reaching a peak in New Zealand in about 1968. This graph shows New Zealand coronary heart disease mortality for males and females from the period 1968 through to 2010. As you can see, in this graph, the age standardised mortality rate for ischemic heart disease shows a marked downward trend over the period. In fact, there was a 70% decrease between 1980 and 2010. Over the period, the male age standardised rate was approximately double the equivalent female standardised rate of death. In 2010, ischemic heart disease was the second leading cause of death after cancer. Males accounted for just over 50% of all deaths. An intriguing question is, therefore, why has there been such a dramatic decline in coronary heart disease mortality over this time? There appear to be two main factors contributing to the decline in cardiovascular mortality. The first relates to changes in diet and lifestyle or other risk factors, which account for about half the reduction in mortality. Of this, reductions in cholesterol, blood pressure, and reduced smoking, along with increased physical activity, have decreased the rate of mortality. The second major area, again contributing approximately 50% to the reduction in mortality, relates to better treatments. And during the course of this talk, I will address each of these areas. Most of the benefits in persons who have established coronary disease come from improved drug treatment and stent treatments after acute heart attack. This huge progress has been underpinned by greatly improved understanding of the causes and treatment of cardiovascular disease. Science has played a crucial role in developing our understanding of the cause of cardiovascular and coronary artery disease. Atherosclerosis is an inflammatory process which affects median and small arteries throughout the vascular system. We now understand that the earliest changes of atherosclerosis can be identified in childhood. When the lining, otherwise described as endothelium of blood vessels, is exposed to raised levels of low-density lipoprotein cholesterol and certain other substances, the endothelium becomes permeable to immune system cells. These cells migrate across the endothelium into the deep layers of the walls of the blood vessel. A series of reactions occur there, attracting LDL cholesterol particles to the site. These particles in turn become internalized to become foam cells, and lesions are formed in the cell wall, which are called an atheromatous plaque. Over time, this will enlarge with further accumulation of lipids, cells, and fibrous tissue. Arteries are vessels which generally carry oxygenated blood to supply the organs of the body. The endothelium is the single layer of cells which lines the inside wall of the arteries in the human body. It provides a barrier between the blood, which is sitting in the lumen of the vessel, and the cells making up the deeper layer of the arterial wall. The endothelium weighs about 1 kilogram in the average human, and in an adult human being has been estimated to comprise a surface area of up to 7,000 square metres, which is hard to visualise. This is equivalent to the surface area of the rugby field at Forsyth Bar Stadium. In small to medium arteries, the middle layer of the vessel consists of smooth muscle cells. And these smooth muscle cells can facilitate changes in size of the artery, vasoconstriction, where the vessel gets smaller, and vasodilation, where the vessel gets larger, which can influence blood flow throughout the body. The vascular endothelium is a complex organ with a large number of functions. It controls vasomotor tone, which we've just discussed, influencing whether the blood vessel can have more or less blood flow. Endothelial cells also determine the balance between maintaining normal blood flow and clotting, which is required to stop bleeding when there is an injury. Endothelial cells have a complex system of chemical sensors and the ability to synthesize multiple mediators. As a whole, the endothelium is the largest endocrine gland in the body, secreting biologically active mediators into the blood. Endothelial dysfunction occurs when cardiac risk factors have an adverse effect on the functioning of endothelial cells. Such factors we've discussed before include high cholesterol, diabetes, cigarette smoking, and aging. Dysfunction of these endothelial cells has a direct consequence of decreasing levels of nitric oxide. And the flow-on effects include vasoconstriction, or the vessels getting smaller, increased platelet stickiness, and clotting. Another adverse effect is increased levels of superoxide, which creates oxidative stress and other adverse effects. So where does endothelial dysfunction fit in the development of coronary artery disease? At the beginning of the process are coronary risk factors, which we've just discussed, including high cholesterol, diabetes, or cigarette smoking. These risk factors are influenced by genes, which determine the risk for coronary artery disease. To date, there are about 46 genetic abnormalities identified which increase the susceptibility to coronary artery disease. Many of these genes are inherited in families, and this is why family history is an important determinant of cardiac risk. The final common pathway, however, is endothelial dysfunction, as evidenced by decreased production of nitric oxide, increased levels of inflammation, and an increased risk of clotting. Given that endothelial dysfunction is a very early change in atherosclerosis, I became interested in using endothelial function to assess the impact of diet on the potential long-term risk of atherosclerosis in human subjects. Now, measurement of endothelial function is achieved simply with a surrogate technique with an ultrasound machine and a blood pressure cuff. A vascular ultrasound probe is used to take an image of an artery in the arm, the brachial artery, and here we can see the probe being positioned over the brachial artery. The next part of the procedure is to inflate the blood pressure cuff for 5 minutes, which leads to no blood flow into the forearm and ischemia of the forearm. After release of the cuff, this stimulates a marked increase in blood flow down the vessel. The increased flow increases shear stress across the endothelial cells, and they synthesize nitric oxide, which is released through the vessel wall, resulting in dilation or an increase in size. This is referred to as flow-mediated dilation. I have an image here of a brachial artery, markedly magnified. It's a relatively small vessel, and at normal size can be up to approximately 3 millimeters. As part of the technique, the blood pressure cuff is inflated above this artery, blood flow stops, 5 minutes elapses, the cuff is released, marked increase in flow, and in the normal situation you'll see that after remeasurement there has been an increase in the size of that vessel. When persons have normal endothelial function, the artery will dilate by between 5 and 15%. In the presence of endothelial dysfunction, the dilation of the arteries is reduced. It is widely understood that a diet largely consisting of high-fat takeaway food will likely result in an increased risk of cardiovascular disease. Deep frying food increases the amount of fat oxidation products in the food and potentially may increase the risk for atherosclerosis. Using brachial artery flow-mediated dilation to assess endothelial function, we assess the short-term effect of dietary fat on endothelial function. We wish to examine whether deep-fried food had a potentially worse effect in excess of its saturated fat content. We therefore enrolled 10 healthy men in this study who were all randomised to each of 3 test meals in random order. My research colleague, Dr. Wayne Sullivan, developed an ingenious method to present a standard meal with varying levels of fat content and fat type. He designed a low-fat meal consisting of a chocolate-flavoured milkshake. The unused fat meal was prepared by adding 46 grams of unused cooking fat to the low-fat meal. To test the oxidation hypothesis, we obtained used cooking fat that had been used for deep frying during a week in a local commercial fast food restaurant. You have to be brave to be a volunteer. 46 grams of the used cooking fat was added to the low-fat meal. The quantity of fat in the added fat meals approximated that which is found in an average fast food meal. The low-fat and unused fat meals or milkshakes were quite palatable. The used fat meal had an initial chocolate taste with an aftertaste of stale burger. Here are the results from our study. Baseline endothelial function is shown in red, and as these were healthy men, endothelial function was normal at about 5% dilation. In the control fat meal, there was no change at 4 hours after ingestion. And similarly, the meal that had unused cooking fat had no significant effect. The used fat meal significantly and dramatically reduced endothelial function at 4 hours after intake. We concluded that intake of a degraded products of heated fat resulted in impaired endothelial function, potentially due to increased oxidative stress. We recommended that in reducing the intake of saturated dietary fats, particular attention should be paid to reducing the fast food intake. These interesting results regarding the potential adverse effects of oxidative stress led us to our next area of research interest, vitamin and antioxidant supplements to improve endothelial function. Kidney transplantation provides an important improvement in quality of life for recipients. But despite this, they have a persistently elevated risk of cardiovascular disease. Transplant recipients have impaired endothelial function and increased levels of oxidative stress. Vitamin C can scavenge superoxide and improve endothelial dysfunction. We therefore undertook a study to determine whether vitamin C could improve endothelial function in persons after kidney transplantation. We enrolled 13 renal transplant recipients in this study. They were fasted overnight and treated with either 2 grams of vitamin C on one occasion or a matching placebo in random order on the other occasion. We assessed flow-mediated dilation of the brachial artery before and 2 hours after treatment with the vitamin C. The subjects, as were expected because of their increased cardiovascular risk, had impaired baseline endothelial function, shown here in yellow, at less than 2%. And there was no change as expected with the placebo. However, after vitamin C, there was a significant 3-fold improvement to near normal levels of approximately 5% in these persons. We concluded that short-term improvement in endothelial function with vitamin C may be secondary to a reduction in oxidative stress. However, to date, there is no improved outcome data to support chronic treatment with vitamin C in this group of patients. Is there evidence to suggest vitamin supplements and antioxidant therapies are of any benefit at all? Many persons in the community believe that there is benefit, and they're prepared to pay for it. You're all aware of this at your local health food shop. Multiple supplements of many types are available. Now, there is a theoretical scientific basis for considering that treatment with supplementary antioxidants may protect against oxidative stress and therefore reduce the risk of cardiovascular disease. However, there have been extensive studies of various vitamin supplements and a meta-analysis of studies, including approximately 250,000 randomised persons, and they've shown a consistent message: no benefit in terms of reduced cardiovascular risk nor mortality. Perhaps of even more concern, supplements with beta-carotene and vitamin E have shown evidence of increased mortality. Interestingly, this information, which is widely disseminated in the public arena, has no particular impact on the consumption of vitamin supplements. Our next area of antioxidant research related to wine intake, which may be of interest to many of you. It has been suggested that regular moderate consumption of wine, and in particular red wine, may be associated with a lower risk of cardiovascular disease. There is debate as to whether the protective effect relates to the alcohol content of the wine or to the high levels of antioxidant flavonoids found in some red wine. We therefore undertook a study to evaluate the effect of red or white wine on endothelial function in 14 men with stable coronary artery disease. After a standard light meal low in antioxidants, participants had fasted overnight, they were randomised to either Cordial as a control or approximately half a bottle of red or white wine over 30 minutes, all before 9 in the morning. Flow-mediated dilation was assessed just before and at 1 and 6 hours after beverage intake. This graph illustrates that at baseline, the participants, as expected, as they all had coronary artery disease, had impaired flow-mediated dilation at less than 2%. There was no particular change in FMD at 60 minutes with any of the beverages, and no change at 360 minutes with red Cordial, which is indicated by the open circle. However, there was a definite improvement in endothelial function with both red and white wine, with no difference at all between the wines. We therefore concluded that wine of either type acutely improved endothelial function, and that this may contribute to the reduced risk of cardiovascular events seen with moderate wine consumption. There is also good evidence across multiple studies that moderate alcohol consumption is associated with a lower risk of coronary heart disease. And this graph shows the risk of coronary disease graphed against the number of drinks, standard drinks per day. And you can see that the lowest risk is in the area of 2 to 3 standard drinks per day, lower than teetotalers. However, once you go over that amount, there's a steep increase in cardiovascular risk. Many ecological studies have suggested that wine is more effective at reducing the risk of mortality from heart disease than beer or spirits. However, there are significant confounding problems with this type of study, including cultural differences. The best evidence suggests there are no substantial differences between wine, beer or spirits in their cardiovascular effects. In other words, the effect is probably due to the alcohol content rather than the contents of the particular drink. In most countries, the cardiovascular benefits of moderate drinking are easily outweighed by the adverse effect size of alcohol, which at present is similar to the global burden of smoking. We then turned our focus of research to the potential antioxidant effects of garlic. Garlic has a very long history of use as a medicinal. You can see illustrations from the ancient Egyptians of garlic bulbs being used for good health. Garlic was used widely in ancient China and is mentioned in Ebers' papyrus, a scroll of about 20 metres long, giving treatments for various illnesses numbering up to 32 with garlic. Hippocrates was familiar with garlic and reported its use as a diuretic. Garlic has been a trusted remedy during epidemics during the Middle Ages. It contains Alicin and other garlic compounds which have been shown to lower blood pressure and blood lipids. There is evidence that aged garlic extract can decrease oxidation and inflammatory factors and slow the development of experimental atherosclerosis. We therefore designed a study to assess the effect of aged garlic extract on endothelial function in 15 men with stable coronary disease. You can imagine it's easier to recruit into a study with aged garlic extract than taking a clove of garlic every day, and impossible to placebo control with garlic cloves. They were randomised in a placebo-controlled trial to 4 capsules of aged garlic extract for a period of 2 weeks, or crossed over to a matching placebo. Flow-mediated dilation was assessed before and after the 2-week treatment period. There was absolutely no effect of placebo on endothelial function. This graph shows the median flow-mediated dilation at baseline in all participants was 4.3%, and that after 2 weeks treatment it had improved to 6.2%. Most of the improvement occurred in the men who had impaired flow-mediation dilatation at baseline. We concluded short-term treatment with aged garlic extract improved endothelial function in men with coronary artery disease. However, any other benefits on cardiovascular risk remain more or less unknown. Despite these favourable preliminary results, there is no conclusive evidence that garlic reduces cardiovascular mortality in patients with cardiovascular disease. There is also no convincing evidence that garlic reduces cardiovascular mortality when used as a treatment for high blood pressure or elevated cholesterol levels. I now wish to turn to the topic of cardiology, which addresses the second major reason for reductions in cardiovascular mortality. Cardiology has made major contributions to better treatments for cardiovascular disease. It takes its origin from the Greek cardia for heart and logia for study. It's a subspecialty of internal medicine which is concerned with the medical diagnosis and treatment of coronary artery disease and many other cardiovascular disorders. The development of cardiology has generally been based on scientific discovery of the pathophysiology of cardiovascular disease. And on the basis of this knowledge, innovative therapies have been developed. Many of our modern cardiology treatment regimes have often been based on large randomised placebo-controlled clinical trials so that we have a firm evidence base for our treatments. Once therapies are introduced into practice, it is part of our important role to audit the results to ensure the treatment is effective and has translated usefully into real-world practice. The birth of cardiology is credited to William Harvey, who was an English physician who first defined the function of the heart. He graduated as a Bachelor of Arts from Cambridge in 1597, travelled through Europe and then enrolled under the great anatomists at the University of Padua, graduating Doctor of Medicine in 1602. Now, before the time of Harvey and the development of his description of the circulatory system, the views of Galen held sway. This dated back to him being a Greek physician and philosopher. He believed that blood travelled between the ventricles through invisible pores, and that the venous and arterial circulations were otherwise completely separated. De Motu Cordis on the motion of the heart and blood was published in 1628 and has 17 chapters which give a perfectly clear and connected account of the action of the heart and the consequent movement of the blood around the body in a circuit. Harvey stated, "It has been shown by reason and experiment that by the beat of the ventricles, blood flows through the lungs and it is pumped to the whole body. There it passes through pores in the flesh into the veins through which it returns from the periphery, finally coming to the vena cava and right auricle. It must then be concluded that the blood in the animal body moves around in a circle continuously, and that the action or function of the heart is to accomplish this by pumping. This is the only reason for the motion and beat of the heart." Further developments in cardiology accelerated in the 20th century. Eindhoven was a Dutch doctor and physiologist, and he invented the first practical electrocardiogram, or ECG, in 1903, receiving the Nobel Prize for his work in 1924. The ECG remains one of our most commonly used diagnostic tools in cardiology and is still used to diagnose an acute heart attack every day in our clinical practice. Werner Forssmann was a German doctor who was the first to insert a catheter into the living human heart. In the best traditions of self-experimentation, he specifically ignored the advice of his department chief and anaesthetised his own lower arm in the elbow region, inserted a catheter into the vein. He then walked some distance to the X-ray department on the floor below, where under the guidance of an X-ray screening, he advanced the catheter up the arm the full 60 centimetres into his own right atrium. This was then recorded on X-ray film, showing the catheter lying in the right atrium of the heart. He was awarded a joint Nobel Prize in 1956 for this work. Regrettably, he was dismissed from his hospital 7 to 8 months after his first catheterisation in a dispute with hospital management. Have things changed? Mason Soanes was an American physician whose pioneering work in cardiac catheterisation was instrumental in the development of both coronary artery bypass graft surgery and interventional cardiology. He was performing an injection of dye into the aorta, the first major blood vessel above the left ventricle, the pumping chamber, when serendipitously the catheter entered a coronary artery and dye was injected, outlining the coronary artery and giving cardiologists accurate pictures of arterial blockages for the first times. Many individuals have made significant contributions here in Dunedin. Sir Horace Smirke was appointed as the first Mary Glendinning Professor of Medicine at the University of Otago in 1940. He described the electrical precipitants of ventricular fibrillation in 1949. He worked with colleagues and developed the importance of basal blood pressure as a determinant of prognosis. There was little in the way of active treatment of hypertension at that time. He developed the Hypertension Clinic at Dunedin Hospital in 1949, which became the first modern outpatient clinic for hypertension, and in 1950 published his findings of the successful treatment of hypertension with subcutaneous injections of methonium compounds, incredibly intensive, patients needing to come in and have calibrated injections of these drugs to bring their blood pressure down, with marvellous results. In 1956, John Hunter was appointed as a lecturer at the Otago Medical School. He went on to become a senior lecturer and the second Mary Glendinning Professor of Medicine from 1962 to 1993. He used his cardiological skills and knowledge for the benefit of many patients in the South. He founded the cardiology department of the Otago District Health Board, established cardiac catheterisation, and developed one of the country's first coronary care units in 1967. He also made significant contributions in the area of cholesterol and lipids and their relationship to cardiovascular disease. Through the 1960s, patients who had a heart attack were admitted to hospital, given morphine for their pain, and then bed rest for 4 to 6 weeks. Ted Nye developed a program of carefully supervised exercise for men post-heart attack after screening with the bicycle exercise test. The initial therapies consisted of graded exercises and subsequently use of the hospital pool. The participants responded well and in many cases had facilitation of a more rapid return to normal physical functioning. The patients then set up the Phoenix Club, which continues to this day, supporting members with heart disease. Dame Norma Restio was trained in both adult and paediatric cardiology and introduced systematic paediatric cardiac catheterisation at Dunedin Hospital. Dame Norma became the second head of the cardiology department in 1973. In 1967, the first coronary artery bypass graft operation was performed at the Cleveland Clinic, and the Dunedin Hospital Cardiac Surgical Unit opened in 1973 with Professor Pat Malloy as the first director. In 1977, the first coronary balloon angioplasty was performed by Andreas Grunzig in Zurich. The first balloon angioplasty in New Zealand was performed by Dr. Michael Ablett at Dunedin Hospital in May 1981. Coronary artery stents were first developed internationally in 1986, and Associate Professor Jerry Wilkins inserted the first coronary stent in New Zealand in 1990 at Dunedin Hospital. Over many years, the clinicians of the Dunedin Hospital Cardiology Department have proven to be early users of new techniques aiming to improve patient management. In 2008, the Cardiology Department were the first who as a group decided to make a wholesale change to a predominant radial artery approach for cardiac catheterisation. Presently, we perform 95% of our catheterisation procedures via the radial artery. During 2008, we performed an audit of our results in the year that we changed. In that year, 165 procedures were performed by the femoral approach, which is via the femoral artery at the top of the leg. We had a complication rate that would be typical of approximately 5%, including injury to the arteries or blood transfusions required because of ongoing bleeding. In the over 800 patients who had their procedures performed by the radial artery, which is the artery in your wrist, there were only 2 relatively minor complications, a 95% reduction with the change to this technique. This study illustrates the major changes or relatively simple changes that can be made clinically to improve patient outcome. What about that major clinical contribution to the reduction in mortality that I discussed earlier? If we look at this study, we're able to quantitate which factors are perhaps most important in reducing cardiovascular mortality. And it's clear that revascularisation produces the largest reduction in risk. And this generally is by coronary angioplasty and stents, or a smaller proportion of patients having coronary artery bypass graft surgery. The next most significant treatment modality is treatment with a statin or cholesterol-lowering drug, followed by anti-clotting drugs, cardiac rehabilitation, and beta blockers. There has been a marked reduction in hospital mortality after heart attack at Dunedin Hospital. Professor John Hunter reported a mortality of 26% in the early 60s, when treatment largely consisted of bed rest for 4 to 6 weeks. So 1 in 4 persons admitted to hospital didn't leave the hospital after a heart attack at that time. Dame Norma Restio prospectively collected audit data for several decades, and this showed a steady decline in mortality from 18 down to 16%, which was influenced by the introduction of aspirin and blood clot dissolving drugs. From the 21st century, mortality has been further reduced by coronary angioplasty and stenting as a primary treatment for acute heart attack. I will now describe the current treatment for a patient presenting to Dunedin Hospital with an acute heart attack. After an initial brief assessment, the patient is transferred to the cardiac catheterisation laboratory. This facility is staffed 24 hours a day by an on-call specialist team consisting of 2 specialist cardiac nurses, a cardiac physiologist, medical radiation technologist, and cardiologist. The patient is first treated with aspirin, anti-clotting drugs, and blood thinners. They are then placed in the cardiac catheterisation laboratory on an X-ray table, and using just local anaesthetic, a needle, illustrated here, is used to puncture the small radial artery at the wrist, which has a diameter of approximately 2 millimetres. A sheath, and here is a sheath lying here, which is a short tube of plastic, approximately 2 millimetres in diameter, similar to the artery, is introduced into the radial artery. And this illustration shows the sheath with the patient's arm going up that way, and you can see that the sheath has a valve, and through this valve, cardiac catheters are passed up the arm vessels to the heart. The cardiac catheters themselves are approximately 1 metre long tubes, and the cardiologist stands beside the patient looking at a screen guided by X-ray fluoroscopy to manipulate the catheters. I'm now going to show a series of illustrations of an actual person presenting to our hospital with an acute heart attack. The tubing here is the catheter, and this is X-ray dye which has been injected into the coronary artery. Normally this artery should run right down the front of the heart to the apex. You can see an abrupt cut-off here of X-ray dye, and this is because there is a blood clot occluding the vessel, and there is ongoing damage to the muscle because of a lack of blood supply. The first step of the procedure is to thread a very delicate guide wire about 1/3 of a millimetre in size through the area of blockage and along the vessel. Along the wire, and here is a picture of a coronary wire, a long catheter of about 1.7 millimetres diameter is passed into the area of the clot. You can see that there's an aspiration lumen, and negative pressure or a vacuum is applied, and the clot is sucked from the heart artery. And here's a specimen container, and these are the actual stringy lengths of clot that have been removed from inside that artery. Immediately afterwards, when we put further X-ray contrast down the artery, you can see a markedly improved appearance with blood flow now down to the apex of the heart. However, there is still some irregularity related to persistent atherosclerotic narrowing and/or clot, which requires further optimisation. This is achieved by implantation of a coronary stent. The coronary stent is again passed down the same guide wire and consists of a metal lattice work crimped down onto a plastic balloon. You can see here the coronary stent, which is indicated by markers. The beginning and the far end of the stent is being positioned across the area of irregularity and is then inflated into position, leaving a nice, smooth, parallel-sized vessel after completion of the procedure. This takes 30 to 40 minutes to perform. The results of this fast and effective treatment mean that after an early presentation there is a marked reduction in the degree of heart muscle damage. Patients are usually discharged from hospital after 3 days and return to normal physical functioning within 1 to 2 weeks. This represents a major advance compared to the early treatment of heart attack. The data I have just shown may give the impression that the battle against cardiovascular disease is won and that there is little left to achieve. Unfortunately, this is far from the actual state of affairs. We have a new epidemic in New Zealand, obesity. This is a worldwide phenomenon and is expected to adversely affect cardiovascular mortality in the future. It is of wide public interest. There wouldn't be a week go by that a headline such as this doesn't appear in the ODT. The New Zealand Medical Association has written a special policy briefing because of the huge concerns about the long-term effects, and in particular, cardiovascular disease is a concern. At the present time, only 30 to 40% of New Zealanders are of normal weight. Related to this increasing prevalence of obesity, there is actually a potential for a decline in life expectancy in the 21st century. We may not continue to see this reduction in mortality if obesity prevalence increases and we have the expected long-term adverse cardiovascular effects. This study shows life expectancy influence with a reduction in life expectancy for persons who are moderately obese and a severe reduction in life expectancy for those who are markedly obese. In this group, life expectancy may be decreased by between 8 and 10 years, which is a quantum similar to that seen with cigarette smoking. For every increase in 2 of the body mass index, there is an associated decrease in life expectancy of about 1 year. We therefore still face considerable challenges to combat this epidemic before the fight against cardiovascular disease is won. I have been fortunate to have experienced an exciting research and clinical career in the field of cardiology over the last 25 years. What is quite evident, however, to me is that the progress achieved here in Dunedin has been a result of the work of a close-knit team, many of whom are present in this departmental photograph from the 1990s. Teamwork has also been an important part of our research program, and I wish to acknowledge all my research collaborators over the years, especially Wayne Sutherland, Greg Jones, and Sally McCormick. The research technicians, including Marie McCormick and David Yeoman, were an integral part of the endothelial function research. The cardiology department research nurses have played an essential role in conducting our research studies, and I'm very grateful to them. I wish to thank my cardiologist colleagues for their support with research projects over the year, and particularly Jerry Wilkins, who has provided long-term support for our local research studies. I'm grateful to the staff of the Cardiac Catheterisation Laboratory at Dunedin Hospital for their great work in both the research and clinical areas. I have found it a personal pleasure to work with the cardiac physiologists and the nursing staff of the coronary care unit and cardiology ward at Dunedin Hospital. Finally, I wish to thank my wife, Fiona, for her support. She's been the core of our family and kept family activities going while I've been away from home working. I'm delighted that my 3 lovely daughters are all here tonight, and I would like to thank them all for helping their mother. I also wish to acknowledge my parents, my brother and sister and their families who have attended to support me this evening. Thank you very much for your attention.
Good evening, my name is Rob Walker and I'm the current Mary Glendinning Chair of Medicine, and it's my very great pleasure firstly to congratulate Michael on his personal chair and also acknowledge what a fantastic talk we've had today. very thorough rendition of our history of medicine, and particularly cardiology in Dunedin, but also the contributions that cardiology has made to the worldwide area of cardiology. Now, Michael's only touched on a very small part of some of the research areas he's done. He has a very strong translational component, as he mentioned, working with Greg and Sally in particular, down at the bench, down to the bedside and back up again. So he's very well versed in many areas of research and contributes very actively to our department. He's one of the key members of the Heart Otago group with some of the colleagues that he's mentioned, and I would hope that in the next year that may also become another research theme that the Department of Medicine co-hosts with some of the other research themes that we do have to carry on this excellent work. So as a small token of our gratitude for such a fantastic talk, just a little gift on behalf of the school and the University of Otago to recognise tonight's events. So congratulations and well done. Thank you very much.